Thank you. So, good afternoon. I'm going to tell you a little bit about what we have found out about the region of Catalonia. And to do that, with this? Yes. So, basically, I'm going to organize the presentation in two parts. One, it's what I think are the key elements of success of integrating healthcare systems. And for me, one of the main conclusions is that you cannot have one without the other. You need the integration. It's the result of many very important elements that if you miss one, then the result is just not the one that you are aiming at. Just to start, let me say, Roberto has explained the main characteristics of the Spanish system. I just want to add some details about the Catalan one for the ones that are not very used to this. So the Catalan health system has a difference, let's say, because we have a lot of care provided by private healthcare providers. Before the healthcare was transferred to the Catalan region, there were already a lot of private hospitals in Catalonia, and then basically when the competencies of healthcare were given to the Catalan government, they became part of the providers of the system. So about 80% of the primary care centers are public, but 20% of the beds of hospitals are public. Okay, so we have a big mix of public and private healthcare systems, and something that is also very characteristic of what we call the Catalan model is this division between public financing and provision. So you can have the financing, it's from the Catalan healthcare insurance, which is public, and then we have different types of providers that offer their services to the public financing. And another thing that I want you to have in mind is that we have 7.6, more or less, million citizens that are being covered with the Catalan healthcare system. Now, this is just to convey the idea that I think it's going to be relevant for many of our areas, that when we think about healthcare and integrating it, we need to take into account the local characteristics. So this is just to highlight how big the socioeconomic differences can be between big cities, rural areas, etc., or also the density of population. So obviously, if we are thinking about integrating healthcare, we can just not do the same thing when we think about a rural area that it's in the mountains, for example, or in a rural area that it's in the sea that receives lots of tourists, or in a big city like Barcelona. And that's the message that I wanted to convey here. Basically, in Catalonia, what happens is that every 4 years, there's a Catalan healthcare plan that determines the key directives of the strategy that the government is going to follow for the next years. And the source of our analysis is the healthcare plan from 2011 to 2015, because this plan really focused a lot on tackling chronicity. And in particular, they developed two types of plans. The first one is the program of prevention and attention to chronicity, and then the second one is integrating health and social care. So what I think is very unique of this Catalan experience is that they've started working on integrating health and social care in 3 dimensions. We have the typical concept of healthcare, we have emergency care, and then also social components. And out of this plan, there were basically 3 main goals. I'm interpreting, so that's my version. To obtain the best possible care for the population, being proactive. Let's just not wait for the patients to come to us. Let's go and find the ones that potentially would be the ones that would need more resources. And then also look for efficiency. Let's use the available resources that we have in the land, in the territory, in the best possible way. To do that, they have these 4 key enablers. This is what I think, that's my interpretation. One, of course, it's identifying the patients that need all these resources. That's the first step. The second one is to share this information. If you don't have electronic care records, it's going to be very hard for you to integrate. This one, and I'm going to talk about that with some detail, it's the shared individual intervention plan, and the last one, the local agreements. I think that the most specific and maybe probably more different ones from what you are used to see are the last 2. Okay, so let me start with some details. I just want to give you some sense. This is from some paper whose writer might be around. So I just want to highlight that there will be two groups of patients that are of a special interest for that. The complex chronic patients and the advanced chronic care patients. Complex are 3.5% and the advanced 1.5%. So we start with the stratification of the population. That's probably not so different from things that you've already seen, but there are two elements that I think are very interesting. So it's not only a matter of identifying the population, but it's also labeling them. Once I've identified the patients that are advanced chronic patients or complex chronic patients, I label them so that everybody in the system can be aware of the type of patients that they are dealing with. The second thing that I think is also very interesting is this proactive approach. The providers were told to look, the primary care in particular, to look for the patients that would fall estimatedly in the region. And actually they were very successful with that. And then another thing that I think is quite special is this. So basically the way in which you identify these patients, it's not only with an algorithm, with objective measures, that's very important, obviously. But then there's something that I think it's very interesting, which is the clinical judgment. You might have two patients that look exactly the same, and one of them lives alone, he's a widower, and his children are very far away, and another one lives with his wife, who is perfectly healthy. These two patients necessarily will need very different type of attention. And this is something that they are including. Okay, so that I think it's the labeling, the identification so that everybody can see them, the fact that it's this combination including social criteria, and then of course there are guidelines for professionals. Once the patients are labeled, you can see this label as a complex chronic patient or as an advanced chronic patient. Advanced means that maybe the remaining estimated life expectancy might not be that long. Everybody can see that. When I mean everybody, I mean every provider. Okay? When I call the hotline in the emergency room, for example, I just call, I dial 061, and they will see which type of patient I am. When the ambulance comes, they know which type of patient I am. Okay? That's something very important. Then that's the other part, the third one, the shared individual intervention plan. And this is one of the things that when I learned about this, I found more interesting. What's this shared intervention plan? It's an individualized, personalized plan. Okay, once you identify one patient that has some characteristics, you personalize the type of care that he or she needs, and it takes into account not only the medical things, the physical complexity, but also the social environment, like the example that I've been telling you about. It's not the same living alone than living with your partner, for example, and also the psychological needs. Do you feel comfortable taking care of yourself or not? Do you feel empowered? Or are you worried that you cannot control your disease? Okay? It also takes into account the patient's values and preferences. And you see what I mean with that. Okay? If you are really, really sick, maybe, you know what, probably at the end of your life or this, do you want to spend more time in the hospital or you prefer to be home? This is important. This has to be in this part of plan. And we need to have a conversation about this, not only with the patient, but also probably with the family. Okay? And this is what it's done. That's why it's elaborated collaboratively between the general practitioner, the patient, the different social care providers if they are involved, and also, I insist, the family. This is very important with this type of patients. Some of them might need the involvement of the family, some might not need that. And it's a dynamic document. This is also very relevant because the situation changes. The chronicity keeps evolving. You might change your mind. You might need something different. Your kids might come back and be closer to you, etc. Okay, so it's very important that it's dynamic and it's periodically reviewed with your primary care patient. And as I was saying, it might include advanced healthcare directives. Where do you want to be treated, in the hospital, home, etc. And of course, this is included in the shared electronic medical records. Because when everybody in the provider side sees you, they need to know what's the plan that you've negotiated, that you've discussed with your primary care doctor, together with the other elements in the system. And that's something that I think it's quite unique. This personalized plan that it's included in the records. with care instructions for everybody. Okay, so what it says is, in case of crisis, what is going to happen? In normal situations, what's going to happen? Okay, and that's what I'm emphasizing. Okay, you have instructions for stable phases and for crisis. So, for stable, what do you have? Contact phones. Who should you call if something is going on? Is it a nurse that is your contact? Is it the primary care physician? What's the WhatsApp? Whatever works for you. Okay. The revision of the medication, follow-up services, etc. The key here is to keep these patients stable for as long as possible. But of course, with this type of patients, from time to time, you have crisis. Then, what happens in crisis? Well, crisis might happen during opening hours of a primary care center or not. And obviously, the plan needs to be there. You can't just feel comfortable managing your disease if you know that there's a plan for that. You know what you have to do in a crisis, you know what you have to do in stable situations. In working hours, you go to the primary care team. Non-working hours, you call 061, which is the healthcare hotline, which will again see whether you've been identified as one of these type of patients. What does this individualized plan include? As I'm showing, this is what you can see. Health problems, medication, who is the person in charge, do you live alone, live in a residence, all this social information as well. Okay, I don't want to spend too much time with this probably, because I want to tell you a little bit more things. Let me just pass, but that's what I was just telling you before. Okay, so you can see directives in case of crisis, etc. Okay, more things. Sorry, it's going very slowly. Let me advance on this, because what I want to tell you now, it's about more. I think I've been stuck in here. It doesn't seem to move. No, okay, sorry. So the third point is the shared clinical record that we've discussed. And then the fourth thing is this local agreement. Okay, this local agreement, I also think it's quite unique of the Catalan model. Basically, this takes into account these differences that I was telling you about before. Okay, because it's not the same if you have a big hospital around you than if you don't have it. It's not the same if you live in the mountain than if you live somewhere that is more accessible. The plans might be different. You might have a region that has a mental care facility or a region that doesn't have it. So obviously, the response will need to be necessarily different. And this has a local focus, and what it does is to develop a care pathway locally. If you have this type of COPD, for example, or diabetes, what's the local focus? What's the local response that we are going to have here? And it's written, and it's a formal agreement. The local providers, the local leaders get together with the objective of getting the best possible health for this type of patients, and they decide how they are going to organize themselves to respond to that. And I think this is kind of very empowering and quite unique. And it establishes the criteria and methods for interprofessional communications. Of course, it has to guarantee a continuum of care 24/7. So you have a local response in working hours, a local response in emergencies, and also very interesting, there are evaluation criteria. Are we doing a good job or not? And that's signed. How is this done? Well, you identify the pathways to organize all the people involved in healthcare, and it gives them the flexibility to adapt to the different characteristics of the territory. And how is it elaborated? I'm just summarizing very quickly, but as you can imagine, it's a lot of work. There's first a group of experts in the national level that set which are the key objectives. Then there's a second group of experts at the local level that basically borrow from that and elaborate their response. And basically, it's transmitted their local response to the Kursaal for their approval, basically just to show what's going on. So let me show you, out of these 4 enablers, which are the results that we have found on this. This is a quite technical paper. What we've done here is to use a synthetic method. What's this synthetic method for the ones that are not used to this? So most of the times, when we have a treatment group, you have to find a control group that is quite similar. And sometimes when you talk about regions, people might not agree. You might say, I know, close to this region, there's another one. That's not the right control. And that generates controversy. What this synthetic method does is to say, look, which are the key elements for you to decide which is the right comparable? Is it the population? Is it the income? Is it the age? Is it the complexity? Tell me what matters. And then, with all this data, the expenditure, all the socioeconomic indicators, the complexity of the hospital, do you have a big hospital nearby or not, population and so on, we create a synthetic comparable. It's invented. It doesn't really exist. It comes from giving different weights to different things. So that I like very much because it's transparent. If you tell me, no, what matters is the color of their eyes, okay, I can put it here. Probably I won't have this data. But you see what I mean, right? So this comparable is elaborated based on the things that you believe that really matter to do the comparison. And then we determine which are the treatment groups and the control groups. Why? Because there was this Catalan healthcare plan that I've been telling you about, but as always in life, some regions really took to it and they adopted it very quickly and they did an amazing job at integrated, and some just lagged behind, okay? And we have different methods to identify which are the real applicants of this thing and the ones that didn't do much, okay? And basically, this is what we see, okay? So this is the treatment. Here, this drop, actually, it's because we just have annual data, so it looks like a drop, but actually I should see points. The drop is here. So what's this thing? This is the avoidable hospitalizations. These hospitalizations that should never happen if the integrated care was working as it's supposed to be, and if primary care was doing all the jobs, etc., right? And these avoidable hospitalizations have been ranked and identified in many papers, so we follow the same identification. The interesting thing here is to see that the synthetic, which is the dashed line, it's the same. The synthetic is created to be very, very similar to the comparable. And then what happens when they start integrating? Big drop. Okay, now we have to be sure that this is something that makes sense. So I just wanted to show you how this is done without entering into many complexities. But the idea would be that what we should see here, if instead of picking the treated one, I pick any other area, the differences should not be that big. So the point is that the difference of the synthetic and my area should be 0 before the treatment, right? Before something happens. They are the same. That's how I create this synthetic. And then after that, I observe a big drop in avoidable hospitalizations, right? They are many, I have less avoidable hospitalizations. This is the one. In the other areas, this doesn't happen. Okay, so that's a good way of checking that something is really going on in this sector that was so good at integrating. And the same thing can happen if you look at the readmission rate. Now here the synthetic is not that good. I must tell you that part of the problem here comes because we would like to have individual data, but unfortunately we could not get it. So we only have data at the very small health area, but it's still not individual, so it's risk adjusted and so on, but I would have preferred to have the other type of data. Just to conclude then, my main takeaways from this is that when you try to do integration, as I said at the beginning, you have to tackle many pieces at the same time. It's a result of many things, and you can just not touch one. You have to decide that you are going to integrate and then just go for it with all the pieces that are necessary. For me, the pieces that were very important are the ones that I already mentioned. The local part is very crucial, I think. It empowers the local providers and it recognizes that one size doesn't fit all. And finally, we have very good results of the countries, of the areas that did integrate. So now I pass it to Anna